are going to present with us, please come. Dr. Shaline, Dr. Neil Banerji, and today we have two case discussion by Neil and exome sequencing with the Indian scenario by Shaline. So I request you to join this important webcast and YouTube live, and we will be discussing the case also. And you will get the insight of what is latest in pre-eclampsia, eclampsia, and how is the management goes on. There is a case which Neil will discuss, and I'm asking Neil to start with his lecture. Thank you.
Good morning, everyone. Good evening, everyone. My name is Dr. Neil Banerji, and I have completed my master's from NSCP Medical College, Agrawal. Good afternoon, good evening, everyone. My name is Dr. Neil Banerji. I have completed my master's in gynecology from NSCP Medical College, Jabalpur. Today, I'm going to discuss a case which is very intriguing and has many facets, and it would be nice to discuss the case. So the question is, a 30-year-old gravida 1, para 1 female admitted to the ward suffers a generalized tonic-clonic seizures. Her pregnancy was complicated by preeclampsia, for which she was taken into the emergency department and oxytocin was infused. IV magnesium sulfate was administered and the line was discontinued a few hours ago. Pitocin bolus, she gave birth at approximately 27 hours ago via spontaneous vaginal delivery at 37 weeks of gestation. Pitocin bolus and hand massage were used to control bleeding. After delivery, the newborn is a healthy baby boy with an APGAR score of 9. Her temperature is 98 degrees. BP is 120/85. The pulse is 81 per minute. Respiration is 16 per minute. Her physical examination reveals a confused, tired female with episodes of vomiting, but there are no focal neurological deficits. The labs drawn right after the seizure show that hemoglobin is 9.9, platelet is 250,000, sodium is 114 milliequivalents, potassium is 3.7 milliequivalents, chloride is 102, glucose is 120, calcium is 10, and magnesium is 6.1 milligram per deciliter. So which of the following infusions is the most effective treatment for this patient? We have four options: hypertonic saline, calcium gluconate, normal saline, and 5% dextrose. So before we answer this, let us take an approach to this question. A 30-year-old gravida 1, para 1 female admitted to the ward suffers from generalized tonic-clonic seizures. Now the first thing that comes to an obstetrician's mind is this is eclampsia. Now we should know that this patient has already delivered around 27 hours ago and IV magnesium sulfate was already given to her. Second point is her BP is in the normal range. So by definition, this makes eclampsia unlikely. And also we have to remember that eclampsia is a diagnosis of exclusion. We have to exclude all the other causes of seizures before coming to the diagnosis of eclampsia. What else do we see in this patient? We see that she was given magnesium sulfate. Now magnesium, and the patient is confused, tired with episodes of vomiting. Now magnesium can cause neurological depression, but we have to remember that the level at which magnesium causes neurological depression is after it causes respiratory depression. We see that this patient's respiratory rate is within the normal range. So we can safely, and her magnesium, which is 6.1 milligram per deciliter, is within the normal range, which is 5 to 9 milligram per deciliter. So we can safely rule out that this is magnesium toxicity. Now we don't think this is eclampsia, this is not magnesium toxicity. What else is the significant finding? We see that her sodium is 114 milliequivalents per liter and chloride is 102. This tells us that she is suffering from severe hyponatremia. She is suffering from severe hyponatremia. Now, what is causing this severe hyponatremia? What is in the question that is hinting us that this is what caused her severe hyponatremia? The question tells us that After delivery, she was given a Pitocin bolus. Pitocin is an oxytocin bolus. Now, we all know, have all read in the textbooks that oxytocin should never be infused as a bolus. Why? Because oxytocin has, along with along with being a uterine relaxant, it also has action as similar to an antidiuretic hormone. It has cross reactivity with vasopressin or ADH receptors. So what happens? It will reduce diuresis and it will lead to water retention. Water retention will dilute the blood and will cause dilutional hyponatremia. So the patient is suffering from dilutional hyponatremia, which now severe hyponatremia. The symptoms of severe hyponatremia is first of all GTCS, then then generalized neurological deficit with including confusion, tiredness, and vomiting. Now, what else can we rule out from this? We have ruled out eclampsia, we have ruled out magnesium toxicity. What else can we rule out? Now, the question is telling us that there are no focal neurological deficits. That means there is no stroke, basically. The question is telling us that this patient does not have any stroke. So, now we have to correct her dilutional hyponatremia. What if we give her normal saline? Normal saline is an isoosmotic solution. It will just increase the blood volume without correcting the dilutional element of the hyponatremia. So this option will not be correct. Calcium gluconate is given for magnesium toxicity. We see that her magnesium level is 6.1, which is within the normal range. 5% dextrose, again, her glucose is 120. There is no hypoglycemia in this patient. So the correct answer will be hypertonic saline. Hypertonic saline will be administered in a 100 ml vial with a rapid infusion. We have to correct at least 4 to 6 milliequivalents initially within the first hour. Then after, we will give her normal saline infusion till the patient regains her complete consciousness.
Thank you, Neil, for presenting this case in. We have a few things to consider that you have told about the tonic-clonic seizures and she is presenting with that. And second thing, you have ruled out the other causes of tonic-clonic seizure, which has to be done. But the thing is, you have told about that we should not put bolus of Pitocin or oxytocin. Why we should not give bolus? And oxytocin is very much frequently used in obstetrics, in inducing labor, in inducing abortion, in preventing postpartum hemorrhage. So, is this a possibility that if Pitocin bolus is given to any such of this condition will create problem? If yes, then what is the ideal way to give oxytocin in a different scenario?
Well, there are multiple scenarios where we could give oxytocin. The most common two scenarios is first is induction and augmentation of labor. The second is prevention and treatment of postpartum hemorrhage. Now, let us first talk about these two scenarios. We will oxytocin is given for induction and augmentation of labor, that which is IOL.
Please.
Induction of labor and augmentation. Now, for induction and augmentation of labor, the recommended dose is IV infusion, which is given slowly over time. We should never give bolus. As I told previously, that oxytocin has antidiuretic action also at high doses and rapid doses also. So oxytocin, if given in a bolus, will lead to water retention and, as we saw in the case, dilutional hyponatremia. So how should we give oxytocin? Oxytocin is given as a slow IV infusion for induction of labor over two types of doses. There is a high dose regimen and a low dose regimen. Now, low dose regimen starts at 0.5 to 1 milli international unit per ml, and high dose will be 4 to 6 milli international units per ml.
एक वेरिएंट जिसके कारण और बच्चों की डेथ हुई और जिसके कारण ये बच्चा भी ऐसा है। अगर हम उसको पकड़ लेंगे तो हम आगे जो आपकी फ्यूचर प्रेगनेंसीज है उसको होना बहुत ना के बराबर हम कर सकते हैं, क्योंकि अगर हम पकड़ लेंगे तो हम वो एम्ब्रियो इम्प्लांट ही नहीं करेंगे, वो एम्ब्रियो इम्प्लांट नहीं होंगे तो वो डिसीज नहीं होगी।
मान लीजिए कि वो एम्ब्रियो के लिए आईवीएफ के लिए बहुत ज्यादा पैसे नहीं है उनके पास, then you can help them in early
amniocentesis.
prenatal diagnosis.
Yes sir, amniocentesis या CVS sir. Carrier screening using exome sequencing is highly elective for identifying couple at high risk, allowing comprehensive, personalized diagnostic and reproductive pathway in highly diverse populations.
That means this sentence, what you are telling, that this is a generalized statement.
Yes sir.
You have to think about, because 3 प्रकार के आपने ग्रुप लिए, एक में जिसमें कि बेबी डिलीवर हुई और बेबी डाइड,
सस्पेक्टेड थे
दूसरे में जिसमें कि उनके घर के इतिहास में, उनके घर के फैमिली में, उनके घर के हेरिडिटरी में ऐसी डिजीज हैं जो कि पास ऑन हो रही है।
yes,
और एक ऐसे होते हैं जो कि आपस में मैरिज दे आर कंसैंग्यूइनस और उनको ये मालूम है कि कंसैंग्यूनिटी में ज्यादा हो सकते हैं।
yes,
तो ऐसे केसेस में आप जो प्रोस्पेक्टिव पेरेंट्स हैं जो कि फैमिली प्लान करना चाहते हैं, this statement,
yes,
again read it.
Carrier screening using exome sequencing is highly elective for identifying couples at high risk, allowing comprehensive, personalized diagnostic and reproductive pathway in highly diverse populations.
That means this paper is saying that they are giving one statement that carrier screening using exome sequencing is highly elective for identify couple at high risk.
Yes sir.
It is your duty to find out which couples are at high risk.
Yes,
and if they are going to reproduce, it is your duty to help them to give an opinion about the carrier screening.
And showing the right pathway.
Yes.
कि how from the
But इसके साथ एक प्रॉब्लम भी आती है शालिनी, कि हम बहुत सारे इंफॉर्मेशन भी उनको देते हैं जो कि वो नहीं चाहते थे या फिर आप उनको पास ऑन नहीं करना चाहते।
सर इसीलिए तो हम ये सबको नहीं कर रहे हैं। इसीलिए तो हम जो हाई रिस्क केस है उनको ही कर रहे हैं।
पर आजकल की डेट में ये भी किया जा रहा है कि जो भी प्रोस्पेक्टिव पेरेंट्स होना चाहते हैं उनका यदि आप कैरियर स्क्रीनिंग जो एक नया अभी, बट वी आर आल्सो डूइंग वन प्रॉब्लम इज दैट गेटिंग द एक्स्ट्रा इंफॉर्मेशन, लाइक जो हमने एक का कराया था और उसमें दैट BRCA1 म्यूटेशन मिल गया, तो बट द पेशेंट इज ओके, बट वी हैव टू गिव, you cannot hide that information also.
Yes, sir.
But this is an extra information which might create and some variant of unknown significance might create
anxiousness to the patient.
To explain. तो ये हमको थोड़ा सा इसका एक साइड एक ड्रॉबैक है। But if you selectively use these techniques in prospective parents which are high risk, like already
category 1, 2 and 3,
so then it is a, because there is हाईली डाइवर्स पॉपुलेशन है।
yes,
आप एक्सपेक्ट नहीं करते हो कि होगा, बट
तभी सर इंडिया में ये बहुत जरूरी है क्योंकि डाइवर्स पॉपुलेशन है सर। हर कोई होता है, उसको अग्रवाल में शादी करनी होती है, उसको इसी में शादी करनी होती है, तो इसके कारण भी बहुत सारी डिसीजेस जो होती हैं वो एक
मोस्ट ऑफ द टाइम दे थिंक्स दैट बेबी इज नॉट डाइंग बट बेबी इज हैविंग इंटेलेक्चुअल डिले।
yes,
बेबी माइट बी हैविंग सम सीजर्स, माइट बी हैविंग सेरिब्रल पैल्सी, माइट बी हैविंग, which is not very evident and not creating death to the baby or death to the neonate,
yes,
but baby survives with treatment, but there is no diagnosis and why it happened.
It is a neonatal development, neurological development sir.
तो बहुत सारी चीजों में आप ये सब
बिल्कुल
चीजें पता कर सकते हो यदि आप ये अप्रोच करते हो। और दूसरी बात ये है कि यदि एक बच्चा ऐसा होता है, यदि आप उसका एक्सोम सीक्वेंसिंग करके ये डिजीज पता कर सकते हो, तो आप reverse back, you go to the parents from where it has come.
Yes, sir.
Then we can find out whether they are carriers of this, if we get something in the living child, index child. So these things are, this paper has been chosen because of this, because it is an Indian, I cannot do blanket सबका करा दो क्योंकि it is a costly investment, but the thing is if we can plan this carrier screening to those couples who are in high risk, definitely we can help them.
Yes.
And I think
thank you so much.
This is a very informative again, और हमारा एक मैसेज ये रहता है, it is not the reproductive medicine, it is not the obstetrics, or it is not the genetics, or it is not infertility, or it is not the fetal medicine. मेरा एक अप्रोच ये रहता है इन फेलोज के साथ, इन बच्चों के साथ में, गायनिकोलॉजी एंड ऑब्स्टेटिक्स एज अ in toto, because you cannot separate out, because you are caring for the family, you are caring for the baby, you are caring for the child which is coming onto the earth. It is your duty that you advise those couples. And आज हमारे पास में 2 केसेस जो एक मैटरनल मोर्टेलिटी को लेके कि मैटरनल मॉर्बिडिटी एंड मोर्टेलिटी फॉर प्री एक्लेम्शिया, जो कि बहुत ही ज़्यादा कॉमन है. वी हैव अचीव्ड सम part of reduction of this menace by doing some intervention which will come with our investigations. And second, यदि बच्चा हो रहा हो तो बच्चा अच्छा भी हो. Thank you very much.
Thank you, sir. Thank you.
And we end this session here. Thank you very much for joining us.